We postpone a question to the end of the session, okay?
Thank you, Dr. Salwa, for the introduction. It's my pleasure to participate in the second Ministry of Health conference. I'll be giving an overview of upper limb ultrasound-guided MSK interventions. And when I talk ultrasound-guided MSK interventions, I'm talking in the domain of pain management, which is an emerging subspecialty that you will see being practiced by radiologists, orthopedic surgeons, anesthesiologists, and so different specialties. But we have an edge in this topic because we will always, of course, use image guidance. We have easier access to image guidance machines, and we can, in some cases, diagnose and provide management in the same settings. So this is our edge. But of course, the prerequisites for that, we need to have intervention skills. We need to know how to guide our needle to the desired target. We need to have MSK ultrasound experience, of course, because we need to know what we're doing. We need to diagnose what's the patient's source of pain. And we also should have clinical skills, starting from taking a proper history from the patient and up to performing some simple clinical tests. This all aims to finding the appropriate source of pain in the patient, which, as you know, can sometimes be multifactorial. This is especially true for, say, spine cases in which there could be several causes that we can see on imaging that may cause pain, but doing some clinical tests can pinpoint the exact cause of the problem. So why image guidance? Of course, it makes sense that image guidance is more accurate and effective, but it is now evidence-based. There is now several papers and researches that show that image guidance improves both effectiveness and accuracy of the injection. So, starting with our core lecture, I will be giving an overview of the shoulder, elbow, wrist, and hand, what we can offer for our patients. Starting with the shoulder. So, this is actually one of the most commonly referred joints for injection. We can do bursal injection. We can do something for rotator cuff tendinitis and calcific tendinosis. Bicipital tenosynovitis, we can do intra-articular injection, and we can do suprascapular nerve block. First, subacromial bursa injection. The subacromial bursa is the bursa between the supraspinatus below and the deltoid and the acromion above. The patient will present by symptoms of impingement. He will be unable to abduct his shoulder, or there will be painful abduction. To diagnose it simply by ultrasound, we can see the bursa easily between the supraspinatus and the deltoid, or by MRI where we can see fluid within the bursa. Sometimes it is not that evident. We can ask the patient to abduct his shoulder on ultrasound and to check for what's called the branching sign, in which the bursa buckles underneath the acromion, becoming more evident. So if we decided that the patient has bursitis and we're going to inject, the patient will be either lying supine or sitting. We'll be injecting in the same plane of the bursa. We use a steroid local anesthetic mixture. And the improvement will be immediate. If the patient cause of pain is only bursitis, improvement will be immediate. But of course, we should tell our patient that this immediate improvement will be temporary, because it's probably the effect of the local anesthetic until the steroid effect takes over. It will take a couple of days, 3-4 days, few days until steroids actually starts working. But again, good patient selection would result in dramatic improvement for the patient. So this is where we inject. Okay, this is where they inject, and this is how it appears after injecting. Clear fluid distending the person. As for supraspinatus or rotator cuff tendinitis, we can we can inject platelets-rich plasma. It's a simple procedure, really, but the main point is that we shouldn't inject steroids into the tendons, because steroids cause weakening of the tendon, and the patient would be more prone to tears. So we shouldn't inject steroids into these tendons. Next is calcific tendinitis. This is the painful condition in which there is what's called calcium hydroxyapatite crystal deposition, or HAD, head disease. This is a painful condition that is quite easily diagnosed by ultrasound, followed by X-ray, and it may be tricky to diagnose an MRI if you're looking quickly, or if there is very little calcification, it may be missed on MRI. So by ultrasound, we can see easily the calcification. We can do what's called barbotage, or serial irrigation and aspiration of saline or local anesthetic. The calcification would be really hard, so you would need to use a large bore needle trying to break through this calcification and inject saline, local anesthetic, and aspirating as much as you can. The procedure is painful. The patient should know that he will be in pain for a few days after the procedure, and then hopefully his symptoms would improve. This is the calcification that can be sometimes drained from the calcific tendinitis. The next, for what we can do in the shoulder, we can do intra-articular injection. This is done for patients with arthritis or osteoarthritis that is resistant to medical treatment. But actually, the most common indication for me is when I'm asked to do MR arthrography. So this is the main indication for me. I prefer the patient to be lying on his side, going posteriorly, trying to get that view by ultrasound, in which we can see the glenoid, the labrum, the humeral head, and we direct our needle into the joint space directly. It's a simple procedure, really. Now we can check real time our injectate filling the joint space. And finally, for the shoulder, I will give a hint about suprascapular nerve block. Well, the suprascapular nerve is a nerve that arises from the upper trunk of the brachial plexus. It gives sensory supply to the shoulder joint capsule and the AC joint, the acromioclavicular joint, in addition to motor supply to the supra and infraspinatus muscles. So we can find this nerve by ultrasound in this location. We put a probe in the supraspinous fossa, and we go as far lateral as possible, trying to get this view in which there is the supraspinatus muscle, and finding this notch, the supraspinous notch, the suprascapular notch, I'm sorry. This is where we will be directing our needle. The procedure is easy, but it provides temporary relief regarding the block. So the pain relief would be for a few weeks. After the pain returns, we can offer re-injection, or we can offer radiofrequency ablation. This is a technique that's now popular for lumbar nerve, but can be used on any nerves, including the suprascapular nerve, and it provides more prolonged pain relief. This procedure is done in patients with severe osteoarthritis, extensive rotator cuff tears who are not going to do surgery. We can offer this treatment for pain relief. Next stop is at the elbow. We can do injection for tennis, golfer's elbow. We can do intra-articular injection. We can inject bursa, like the olecranon or the bicipitoradial bursa. For tennis elbow, the patient will be complaining from pain at the point of the lateral humeral epicondyle that is accentuated on rest pronation and flexion. Okay, we can test it to make sure that this is the cause of pain. And of course, by ultrasound, we see the features of tendonitis and or MRI. Treatment, again, PRP or platelet-rich plasma are preferred when we're doing intratendinous injection. But we can also do, prior to injection, we do what's called dry needling. Simply going by a needle and trying to make micro tears within the tendon and abrade the periosteum at its attachment, the bone. We just go back and forth before injection. This causes micro bleeding that can have, in theory, similar effect to plasma or platelet-rich plasma. So it's a simple, and you do it in all cases. Bursitis, paracebitoradioideal bursitis, is a rare condition actually. On ultrasound it may look like tenosynovitis, but it is not, because this tendon is devoid of tendon sheaths. Again, you can aspirate this bursa and inject whatever you're going to inject, whether steroid or BRB, whatever. Finally, the wrist and hand interventions. We can provide treatment for tenosynovitis, trigger finger, and we can do intra-articular injection. Starting with tenosynovitis, inflammation of the tendon sheath. It is, of course, as you know, it can be part of a more systemic process in patients with rheumatoid and lupus and so on, but it can present as an isolated problem. The most common of those is decurvent tenosynovitis. Clinically, the patient would be presenting by pain at the radial side of the wrist, which can be accentuated in this position by asking the patient to flex his thumb and forcibly, you will do the forcibly, ulnarily deviate his wrist. He will feel sharp pain at this location. By definition, it is tenosynovitis, the first extensor compartment tendons, which are the abductor pollicis longus and extensor pollicis brevis, whatever. My main point here is to diagnose it. You will, by ultrasound, you will see thickening of the tendon sheath with or without fluid. So it's, not all cases you will see fluid within the tendon sheath. What you are looking for is thickening of the tendon sheath.
Excuse me, Dr. Tarek. Excuse me. The crying baby can be out of the floor, please. The crying baby.
من فضلكم اللي معاها بيبي لو سمحتوا تطلع بره القاعة لو سمحتوا.
Okay, you can continue, Dr. Tarek.
Okay. As I said, what we're looking for is thickening of the tendon sheath. In order to inject it, I prefer the axial plane. I view the tendon in the axial plane and go in an in-plane technique. The tendon sheath would not take much fluid, only just 1 cc of steroid plus or minus half cc of local anesthetic would be enough to feel the tendon sheath. And sometimes you would feel resistance even with fewer amount. The tendon sheath would be filled with fluid and you will not be able to inject more because it is filled. And of course, don't inject the tendon. Again, as usual, don't inject steroids into the tendon, into any tendon. Trigger finger. Trigger finger is, we have several fibrous bands that is crossing the flexor tendons in our fingers that aim to prevent the tendon from sagging when we flex. So there are several pulley systems, the most important of which is the A1 pulley, which is overlying the metacarpal, the MCP joint. On ultrasound, we may in patients with trigger finger, we may or may not see thickening of this A1 poly, but anyway, the treatment is to direct our needle into this poly, trying first to do dry needling, going back and forth to break the fibrosis, and inject again a very small amount of steroids plus or minus local anesthetic, and again don't inject the tendon. Intra-articular injections, we can do radial unit injection. Again, the main indication is for MR arthrography, but we can do it again patients with resistant arthritis. What's more interesting is the injection of the small joints of the hands. It's actually very easy. We're not trying to go through the joint line or the joint line itself, because the joint has recesses. The joint, when it is affected by synovitis, synovial hypertrophy, the recesses become distended by synovitis or fluid, and this is where we will direct our needle. Again, if a patient comes to you for this injection, check first that there is actually synovitis or effusion, and again, axial plane, in plane, target this synovial thickening with the dorsal, through the dorsal or the oral aspect. I prefer the dorsal because it is less painful. And again, half cc would be enough to fill the joint. Thank you very much for your listening. I hope it encourages you to do these procedures. Thank you.